Hello, everyone, and welcome back to the gastroenterology track. I'm Pratik Sharma, professor of medicine at the University of Kansas School of Medicine in Kansas City. And it's my pleasure to lead today's session on gastroenterology, in which we will be discussing the current and the future applications of artificial intelligence and machine learning in gastroenterology. Just like all of medicine in the past few years, there has been a significant increase in both the interest as well as the research which is being done applying machine learning and deep learning in both gastroenterology, but also specifically computer vision and endoscopy. So module 2 in gastroenterology. As I mentioned, this is the present and the future applications of machine and deep learning. And it's my pleasure to have our two speakers and panelists here, Michael Byrne and Shravanti Parasa. First of all, Michael Byrne, who's professor of medicine at the University of British Columbia in Vancouver. Michael's also one of our stars and leaders in the field of artificial intelligence in gastroenterology, is a CEO of Satisfy Health and has been at the forefront of AI and gastroenterology and endoscopy. So welcome, Michael.
Okay, thank you, Pratik, for the intro, and thank you to AIMed for the invitation to speak today. So I've been asked to speak on AI in gastroenterology and endoscopy overall, and to see where are we at and what is the future. Sorry, my name is Michael Byrne. I'm a clinical professor of GI in Vancouver, just for your information. Should we start that again? Should have introduced myself. I guess I was Andrew. Sorry. Yeah. Yeah, sure. Yeah, of course. Yeah, just want to make sure. Okay, got it. Thanks. Thank you, Pratik, for the introduction, and thank you to AIMed for this invitation. My name is Michael Byrne. I'm a gastroenterologist in Vancouver, and I've been asked to speak today on the application of AI in gastroenterology and endoscopy. Where are we at and what is the future? These are my conflicts of interest. So if I know our colleagues in radiology have led the way here over the last several years in AI, but undoubtedly AI is very much in our world now in gastroenterology. These are just two of our journals in the last few months that have dedicated the entire edition to artificial intelligence. So absolutely, AI is up and coming in the world of GI and endoscopy. And why do we need AI as endoscopists? Well, in the last 10, 15 years, certainly we've had lots of improvements in the endoscopy technology that we use on a day-to-day basis, better resolution, improved lighting, better forms of virtual chromoendoscopy, and on and on. And yet, despite that, the human eye is not necessarily able to appreciate the detail that's on the screen and extract the information from the data. And we absolutely need help in improving real-time detection and diagnosis of GI cancer and other GI diseases. If you're still a naysayer and you're unclear as to whether we need some help, here is an example of a technology over the last 2 or 3 years. This is volumetric laser endomicroscopy. It's a form of optical coherence tomography. And this is used in this instance here to scan the esophagus, looking for Barrett's and for cancerous change. And I don't know about you, but I would really struggle to know what it is I'm looking at here. It looks to me more like a seismograph looking for earthquake activity. So undoubtedly, we will need some help, some built-in intelligence for this kind of interpretation. And again, if you wonder if AI is not yet up and coming in the GI space? Well, I'm afraid that the main endoscopy manufacturers don't agree with you. Here is an offering from the four main players really right now: Fuji, Olympus, Pentax, and Medtronic in the AI space here in endoscopy, all of them with CAD-E or computer-aided detection offerings for colon polyps. Here's one example. This is the Medtronic offering GI Genius. Again, this is a CAD-E detection type work here. You can see here the green bounding box showing us as a polyp. Now, of course, this is a pretty obvious one. And if you really think this is a distraction and you don't want it, then it's very easy to turn off the module. But it's already been shown in several studies that this kind of tool can help improve our ADR. And of course, that is one of the key aims in endoscopy. What about the field of optical biopsy? So in other words, being able to perform a visual histology, virtual pathology, looking at the polyp in real time. So we know that expert endoscopists can do this very well and potentially allow for so-called resect and discard, where you remove polyps and send them, put them in the garbage rather than sending them to the lab. However, this ability to have high confidence and high accuracy prediction doesn't translate outside of these expert groups necessarily. So I'm going to show you here just a quick video footage of some of our work looking at some CAD-E and then followed by CAD-X or optical biopsy, computer-aided differentiation at a endoscopy webinar just over a year ago.
We have shown you now this new technology with the Medtronic. So we have.
I'm just going to show a quick video here from a conference last year showing some of our work for computer-aided detection, followed by computer-aided differentiation for colon polyps.
So we have shown you now this new technology with the Medtronic system, and now it's my pleasure to introduce Mike Byrne. He came this night from Vancouver, and we tested another system, but we did it before starting in the morning. So the same patient you saw around will explain what his system can do and what is the difference. Mike, please.
Thank you, Helmut. So we're going to show a 2-minute. You can see here we're in CAD-E moving detection mode, picking up polyps here with our CAD-E. And when Helmut goes into MBI, we get an almost immediate call that this is a non-adenoma, even with a little bit of blur on the lens, as you can see. And there's a small neighboring adenoma, which we're able to toggle and pick up as well.
So, of course, these tools need to integrate into our daily workflow. Otherwise, they truly can be distractions. So how do we achieve this, and what are the barriers? This is one early example of trying to look at these tools in day-to-day practice. 2 screens here, and one may say this is not the way that we want to work as endoscopists. So there's clearly a lot of work in terms of how to integrate these kind of tools into our daily practice. What else do we need to look at? Well, it's not just about picking up lesions and being able to optically diagnose what it is we're looking at. It's about improving our performance overall. We all know as endoscopists that we should be spending a minimum of 6 minutes withdrawing the scope from the cecum during screening colonoscopy to maximize our chance of picking up lesions and finding polyps. But it's undoubtedly the case that many people don't adhere to this guideline or recommendation. And why is that? Well, there's currently a lack of supervision, and maybe one could argue there's a lack of practical tools in this regard. Here is a nice model from Honggang Yu's group looking at AI-based tool to determine how quickly the endoscopist is withdrawing the scope and to give some feedback in live time. So you can see here, this is a fairly quick withdrawal. This is a less than 5-minute withdrawal, and there's a speedometer type image on the left there showing you that the foot is on the gas too much, and we're in the red zone here. And you can appreciate, even if you're not an endoscopist, that the image is really quite quickly moving on the right there. If I fast forward to a greater than 6-minute withdrawal, you can see here that we're in the green zone, and the image is a lot easier to look at. We're withdrawing the scope a lot more slowly and looking at a lot more of the surface area of the bowel. So hopefully this translates into a better polyp detection rate. Similarly, this work is from Google Health. This is the C2D2 algorithm. Essentially, the idea here is this model is able to reconstruct a 3D model of the image of the colon, effectively showing us the areas that we have seen and that we have not seen. I don't think any of us will be desperately surprised to know that we do not see all of the surface area of the colon during colonoscopy. So any tool that tells us how much of the bowel we've actually seen can only be encouraged, surely. But it's way beyond just polyps. Much of the work in GI has focused on, for AI, has focused on colon polyps for detection and differentiation. But there are opportunities in Barrett's, in early gastric cancer, in inflammatory bowel disease, pancreatic cysts and cancers, capsule endoscopy, and robotic and endoscopic surgery. I'm going to show just a few examples here of some of that work. We'll talk a little bit about IBD or Crohn's and colitis. We'll talk about early GI cancer in the esophagus and the stomach, and how AI can potentially help us make some decisions regarding whether or not that patient is suitable for endoscopic mucosal resection, endoscopic submucosal dissection, or surgery. So first with ESD, or endoscopic submucosal dissection. This is very much a technique for the advanced endoscopist, and our aim, of course, is to achieve an R0 excision and have a curative resection. This is some work from 2019 from Wu's group, looking at how AI can help in assessing the presence of malignancy and also potentially depth of invasion, in this case in the stomach. And you can see on the bottom row, the areas in black is essentially a negative imprint of the areas of concern that the AI is seeing. And if you go straight up above each of those images to the endoscopy picture, you will be able to appreciate that the concerning looking areas correspond with the black areas. This is some video work from another group. This is from Tada's group. Hopefully this kind of lesion we will all see during endoscopy, just coming up here now. So that lesion on the right of the stomach wall, hopefully we would all see that and recognize that that is indeed a biopsy-proven cancer. But if I fast forward here, this is a more worrisome finding to me from this AI model. This also proved to be an invasive cancer, believe it or not. And I think many people would look at this and think it was an inflammatory area, a benign ulcer of not too much concern. So again, if you think we don't need tools to help us, then hopefully this shows that we've actually got a long way to go in terms of improving our own accuracy. This is a suggested schematic workflow here for such a model. So we use an AI model trained on various imagery from gastric cancer, and this allows for potentially for depth of invasion estimation, and allows you in real time at that time to determine, is that patient suitable for endoscopic resection techniques, as we've just discussed, or do they need to go for surgery? Similar work in Barrett's esophagus and esophageal cancer. This is from Helmut Messman's group out of Augsburg in Germany, and they trained their model on many images and came up with significantly high accuracy, as you can see in this particular paper. Here is a short video from one of the investigators, Alana Egbibo, again shown at the live endoscopy forum about a year ago.
The patient underwent random biopsies, as the moderator had said initially, and now I'm in the stomach, or in a small hiatal hernia. I'll go back again, and the difficulty for non-expert endoscopies is in detection. But even classification and delineation can be extremely difficult. You see a number of blemishes and red spots and biopsy lesions. So it's usually very difficult to distinguish these lesions from one another. And of course, we chose a patient with a slight subtle lesion, which is obvious here in the 12 o'clock position. Especially if I go in the near focus mode, you can appreciate it's quite subtle. It's not very obvious, but you can see the clear demarcation line. And now, if we can switch, I'm not sure you're seeing the AI screen. Can you see the AI screen?
Yes.
Thank you. So now I can switch in and switch out and always perform a probability score. Now the AI doesn't tell me whether it's cancer or not. The AI just gives me a probability, and at a threshold of 90% for this area, with a beautiful heat map and beautiful demarcation and segmentation line, I can always say in real time whether there's a high probability of cancer here or not.
So hopefully that gives you some ideas as to what AI can do right now and where we're going to go in the future. So just finishing up here, I wanted to talk a little bit about inflammatory bowel disease. We've talked about how AI can help in the screening process to augment what we do on a day-to-day basis, how it can help in diagnosis and transform our work. But what about true revealing and treatment planning? Can we, for example, use AI to predict personalized response to biologics in Crohn's and colitis in inflammatory bowel disease? This is some work from my own group looking at how we can apply AI in the field of ulcerative colitis to give an automated Mayo score or the more detailed UCEIS score, and also to show to the reader here of this video the areas of most concern and the areas which are unreadable. So here is a little bit more detail on this kind of user interface, where this is for a central reader, for example, for clinical trials. The reader can choose the video. The model will give a Mayo and the UCEIS score, and will also allow the reviewer to review the sections first with the highest scores, with the ultimate aim here being to give the highest score for eligibility for clinical trials. So hopefully AI will really help to transform the field of Crohn's and colitis as well in terms of disease activity and also prognostication. So in summary and conclusion, there have undoubtedly been significant advances in the quality of imaging in endoscopy, especially in the last few years. Real-time detection and optical biopsy is possible. AI will play a significant role in the near future. One could argue now and in the longer term. I think we will be rewriting many of our classification systems for disease from an AI-centric standpoint, and that many of these newer technologies will really struggle unless there's some kind of built-in machine intelligence. We do know that AI has several potential downsides and can potentially be a distraction in the world of endoscopy. But if we're careful and we take the right measures, I think the benefits far outweigh any concerns. So with that, I'll thank you and pass you back to Pratik.
Shravanti is a practicing gastroenterologist at Swedish Medical Center in Seattle. She has expertise in epidemiology, biostatistics, and more recently has developed this passion for artificial intelligence, is part of the ASGE, or the American Society for Gastrointestinal Endoscopies task force on artificial intelligence, and again, one of the leading experts in the US on artificial intelligence. So welcome, Shravanti.
Thank you very much for your introduction, Pratik. And I am Shravanti, and today I'll be talking about the applications of AI to gastroenterology and what the future holds for us. You already know what's going on in the endoscopy and computer vision space that Michael Byrne has talked about. So I'm going to talk about non-computer vision applications of artificial intelligence today. Here are my disclosures and some of the references that I've used in my presentation if you want to go back. So a brief outline, I'm just going to talk about the current challenges that we have, and Mike already covered quite a few of them in the endoscopy space. I might talk a little bit about what is going on in the gastroenterology space as well, and the current state of technology and how this can be translated into applications in the gastroenterology field. So I will just cover a little bit in computer vision, natural language processing, conversational AI, and also some recent developments within gastroenterology that are not commercial products yet, but could be in the next few years. So basically, any AI technology, if you look at it, is kind of helping us augment what we see and augment the performance of the physician. So in the endoscopy space, we are augmenting the visualization so that we can actually see patterns better and also help us detect lesions and also help with making sure that we have done a good job once we've done a resection. So that is augmentation. Now, if you look at different aspects of AI and how it's impacting medicine, especially right now during the COVID pandemic and shortly after, we do have virtual assistants that are already being used for pre-procedure instructions, instructions, surgical concierge service. For example, if you have a problem with your manometry catheter or a pH catheter or your scope, you could probably have somebody come up onto the screen right away. We are using AR, which is augmented reality, virtual reality, and also mixed reality more often within the space of medicine. This can be used to improve patient education. Most of the time, we are using it to reduce pre-procedural anxiety. In some cases, especially in the world of functional bowel diseases, it is extensively used for cognitive behavioral therapy as well. Now, touching a little bit on cloud computing, because this could be how our AI algorithms can actually be used among an enterprise hospital system, or it helps with the interoperability. That is because it enables APIs for computer vision, NLP, event monitoring, and deployment of several AI algorithms simultaneously as well. Also, there is a tremendous, research going on in sensors, multimedia inputs, and so forth that are helping us kind of monitor patients on the continuum rather than in an episodic fashion. Now, briefly touching about AI and machine learning and how we are using it within GI space already is in risk prediction. There is a gastroenterology paper that was published last year that looked at improving the risk score of GI bleeding using machine learning algorithms. There are several algorithms also looking at risk for cancers, including colorectal cancer, early onset colon cancer, and so forth. It also is used for multimodal diagnosis. When I mean multimodal diagnosis, when we look at a patient, for example, as a physician, when we are looking at a patient, we are looking at the pathology report, the endoscopy report, their history in terms of their risk factors, and so forth, and the medications as a whole. But when we are actually developing risk prediction models and diagnostic models, most of the time the diagnosis is in independent silos. So combining all those silos together to develop a risk stratification score is what we call multimodal diagnosis. A lot of research has been going on in that space as well, as we combine whole slide imaging, which is a pathology-based AI systems that can be built with that, along with endoscopy images and patient characteristics as well. And we just learned about how AI and machine learning are used to improve endoscopic evaluation via computer vision algorithms as well. Precision medicine is another evolving area where because of the large quantities of data, in the past, we were not able to make any sense of it. But with the compute and the speed that we have right now, as well as the vast groups of data in terms of genomics, microbiomics, radiomics, clinical characteristics, and the EHR data, you are probably able to see strides in precision medicine as well. Now, one of the other areas that I would like to touch on is drug discovery. So, and the average cost of bringing a medication to the market, it's about $2.6 billion in the last 15 years or so. And it's unfortunate that most of these drugs actually do not make it to the market because they fail in the drug trials. So AI is helping us solve some part of this problem, because instead of using the target protein or how that protein would actually behave in a human body, you can actually simulate based on existing mechanisms and existing experiments. You can actually see if the protein is going to be successful in the human body or not. So this drastically has reduced the time for generation or even prediction of new medications to less than one, from 10 years to less than a month. So a lot of these pharmacy companies have already have machine learning and AI sections where they work on development of new medications as well. This could be IBD medications, cancer drugs, and immune therapies as well. Now, this is something I use on a daily basis, what we call AI voice technology. A lot of us are already aware of medical dictation systems. Now, the newest trend in this tribe is actually an AI scribe, where you can be with a third, like a smart speaker in your room, and you might be in a virtual visit or in-person visit. And the AI scribe will actually do the scribe for you in a structured format, so the documentation is also easier. I also touched on AI assistants for healthcare consumers in the past, where you can have conversational AI bots that are sending information to the patients as to when they need to take their next drink or whatever. Now, another area that is not well mentioned in our medical conferences is medical literature. We have noticed like tremendous doubling of medical literature in the last decade. Actually, in the last year, especially during the COVID pandemic, the doubling time of medical literature is almost like a month or two. So AI is also helping us in that space as well. So we've done a study looking to extract images from existing medical literature and try to develop the captions so that you can actually use this kind of software in the future, let's say in an endoscopy room, and you'll have your virtual reality, your augmented reality glasses, and you can say, hey, how does a neuroendocrine tumor in the stomach looks? And instead of it bringing up random Google images, it will the system will bring up images from literature which are already peer reviewed, and you can use it as a good reference tool as well. Another use case that we have developed for medical literature using COVID papers is to see, instead of just mesh term search where you are asking, okay, what is the relationship between vitamin D and risk of, IBD or something like that, you can actually, this kind of meaningful AI software can actually comb through the literature and tell you, kind of understand the sentiment as to where you're coming from in asking the question, and tell you exactly what kind of papers make sense. So this is an example where we looked for a search for SARS and ARDS treatment. So it gives you, this is the argument 1, this is the argument 2, and then it gives you the article and the relevance and the paper. And it also actually brings you the exact segment within the paper where the argument thinks it makes sense, and you can directly go to that part of the article as well. Now, we've done that, but how is it actually used in clinical application? So this is an example of how that kind of architecture that was built at the Allen Institute for Artificial Intelligence is being used to improve clinical search. So for example, in this search, what we are looking at is what is the role of adalimumab, which is a TNF-alpha blocker, for Crohn's or mucosal healing in ulcerative colitis. So it brings up the actual drug, the medication, what the effect size was in terms of in that particular study, what the number of patients are in each of those studies, and is it a randomized control trial, and what is the total effect size of that medication. An extension to this is also that you can automatically calculate the meta-analysis for this kind of sequence of studies that you have. So we probably no longer would need in the future formal meta-analysis because it might be automated. So this would improve your search. It is basically an AI-infused search to get meaningful insight, and also helps with quantification of results. Another area that we struggle with in medicine is insufficient quantity of training data. So one way is for all of us to rally together and develop a big database where we can have all this information. But the other way is also using AI technologies themselves to generate more data. And one of our work has been on generative adversarial networks for data augmentation to develop additional data in terms of colon polyps. So in this image, what you see are real images of colon. And what the computer scientists do is develop masks for each of these images and basically transpose them into other colon lumen images, generating near real looking colon polyps. So these are the generated samples and these are the real samples. So we asked a few experts to kind of label in a blinded fashion which ones were real samples and which were generated. And the experts could not differentiate between the real samples and generated samples. Other area of active research is also your omics research, especially in gut microbiome, personalized nutrition. That's a big one there, especially with wellness companies, including big tech giants, and also finding metabolomics and gut bacteria as well. So this one is one of my favorite work here, too long didn't read. So we have a lot of literature out there that we can't keep tabs on. So there is a new AI software called GPT-3, where it actually is able to generate human-like summaries of articles, which is already being developed in computer science, and Microsoft actually uses it for their journalism as well. So very soon we'll see some of that in the field of medicine as well. So I'm excited about that. That's all I have for today, and we'll go on to the discussion.
So let's start off with some questions to both of you and try to gauge your answers and where you think we stand with machine learning pertaining to gastroenterology. First and foremost, are these tools decision, support, or diagnostic? What do you think of that?
So I think that's an important question to ask, because right now, regulatory bodies are concerned, understandably, about making these standalone diagnostic tools. So I think we're in a space really where these are clinical decision support tools at this time. They're tools to improve our technique, to improve our pickup of disease, our accuracy, help hopefully inform our decisions better without being the decision maker. And that's until we get user confidence, we get patient acceptance, we improve the models. But ultimately, I think many of these tools will be standalone diagnostics, in my opinion, but I think we're a little ways away from that. Shranti, what do you think?
I agree with you, Mike. I think this can't be standalone at this time just because of the medical legal implications as well, because the diagnosis still has to be done by the physician. But in the future, because AI models are all iterative, they could be more accurate, and from different data sets could be more generalizable. So at that point, maybe 5 years from now, I have no idea what the FDA is thinking. But at this point, I think it's basically augmenting our performance. So the best we could say is it is a clinical decision support tool.
Right.
Very well. Let's talk about some concerns about artificial intelligence and endoscopy. Now, we know that they're bounding boxes. There are these beeps which go off during colonoscopy, which may highlight a polyp, for example, during the procedure. But is there a concern that this will make the endoscopist lazy?
I've heard people talk about the self-driving car analogy when this comes up. Now, that might be a dangerous one, because some people think you really can just sit in the seat, not look at the road, not hold the steering wheel, and not have any kind of control over the car. But I think most of us would say, you would, even if the machine is driving most of the situation, you're still looking in your rearview mirror, you're still paying attention. And these tools are not magic, right? So for example, the detection tool, as we showed there in my talk, if you pull the scope out really quickly, you're going to miss things. You're going to miss surface area. That Google algorithm shows us that we miss a lot of the surface area of the colon. So relying on the machine to beep every time there's a polyp and you're just not paying attention at all is clearly not going to work. Will result in actually potentially lower polyp detection or ADR. So it's an understandable question and concern, but I think with enough guidance and people understanding how these machines work, and that we bring in also explainability layers here, so that it's not just a black box. I think if we get to that point, and the users have a better understanding of the limitations of the techniques and the AI tools, then we'll hopefully avoid that concern about laziness or over-reliance.
I agree with you, Mike. I think over-reliance is the right word here, rather than saying laziness, because we cannot leave it up to the machine. It's not like we are driving at an autonomous level 5, right? So it's still helping us recognize polyps that we probably not recognize or miss them. It's trying to get the whole community back up to that ADR of maybe 40% or 50% or whatever those great numbers are. So at this point, I think we cannot over-rely on the systems, but in the future, they could be better, but at any point of time, they're just improving our performance.
The other question which comes to my mind is that we all know that there is this black box with algorithms in it, which is helping us recognize lesions, recognize polyps, and tell us whether it's pre-cancer or no cancer. Do we really need to understand how the AI or this black box is coming to its decision?
I would say probably no, because explainability is very important in medicine. For example, traditionally, when we look at evidence-based medicine, right, we know how statistical methods work, in the sense we know we have these limitations when you're using a particular kind of regression model or so forth. So for greater acceptance, I think it's very important for clinicians to actually see the layers as to how these computer vision algorithms, for example, are being detected, like you can show the edge. And I think a lot of work is also going on in actually developing explainability tools as well. And I think that will kind of, along with the results that we see from randomized control trials, will help clinicians adopt this technology better.
Yeah, I agree with that. I think mostly, I think the explainability in medicine is important. We do try to practice evidence-based medicine. If the evidence isn't there and we don't know how decisions are made, then it is tough to get confidence. I think that may change though over the next 10, 20 years as AI becomes more and more ubiquitous and we have greater confidence in what it can and cannot do. If it's confirmed in the next number of years that truly these tools are incredible and that the output is very reliable, then maybe we have more confidence and we don't have to peel apart every single layer. But absolutely, in the world of evidence-based medicine that we've all trained in, it's very key right now to have that visibility as to how machines are making decisions and helping us in our day-to-day practice.
Thank you for that discussion. Very helpful. Now let's talk about some of the controversies around adenoma detection rate, for example, or finding the number of adenomas during colonoscopy. Many of us are experts, and I would say that my ADR is just fine. And I really don't need the help of a machine to tell me where the polyps are. My eyes are as good as that of the computer. Can both of you discuss that?
I would say, all of us can get better. If you're, I've had this question posed to me before at one of the fora last year. Somebody basically said, my ADR is, I don't know what it was, 45%, and so I'm good. Well, we know from the studies that if you can improve your ADR even a small amount, we're saving lives by reducing colon cancer mortality. So why would you shun a tool that's going to make your ADR go from 45 to 50%? And even more important for those whose ADR is 30 or less. So I think to say that I'm good, I don't need any help is quite an arrogant position to take in medicine these days. In terms of the turf, the reimbursement, the allied people in GI groups like pathologists, yeah, of course, that's a more difficult debate, I think, to have. But things change, right? We have much more cross-sectional imaging now than we used to. So that changed some people's world. The cardiologists now have taken a lot of the turf of the cardiac surgeons in terms of valve replacement. So things change over time. And if a machine is now helping an endoscopist be more independent of a pathologist, then that's an evolution. And hopefully it means the pathologist can focus on other more important disease and difficult disease rather than, let's say, boring and small colon polyps.
I agree with you, Mike. I think one other way of putting this is actually saying your ADR is 45 or 50, that's great, but that's an average. What we are looking at is improving the outcome for each single patient. All of us as humans, we have some fatigue when we are doing the procedure, maybe a 12th colonoscopy of the day, right? You may or may not, and every day is not the same, but there's no machine fatigue. It's still performing at its optimum level. So I think those small things will add to incremental value and benefit for the patients and for the physicians in terms of their quality metrics.
Okay, that brings us to the end of this module. And again, Mike and Shravanti, thank you very much for your very comprehensive but very informative answers as well. And thank you for taking the challenge on addressing some of the controversies surrounding the field. So this was a great session, and I hope all the listeners have enjoyed it, and you'll tune in again for our next module. But now we will return to the main plenary session for an open forum discussion. Thank you.